Hi friends, in this video of ECG basics, today I will talk about left posterior fascicular block. First is the disclaimer. Caring Talks YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. The ECG criteria for left posterior fascicular block is right axis deviation more than equal to 90 degrees, RS complexes in lead 1 and AVL, QR complex in lead 2, 3 and AVF, prolonged R wave peak time in AVF. But note that the diagnosis of left posterior fascicular block can only be made after excluding the other causes of right axis deviation. There should be no evidence of right ventricular hypertrophy. There should be no evidence of right ventricular hypertrophy, and there should be no evidence of any other cause for right axis deviation. So the ECG criteria is right axis deviation, RS complex, that is small r, and big S complex in lead 1 and AVL, QR, that is small q and dominant R complex in lead 2, 3 and AVF, and prolonged R wave peak time in lead AVF. The typical ECG in this picture shows slightly prolonged QRS duration, prolonged R wave peak time in lead AVF, and RS complex in lead 1 and AVL, that is with small R wave and deep S wave. QR complex in lead 2, 3 and AVF, that is small Q wave and tall R waves. Right axis deviation in lead 2, 3 AVF are positive and lead 1 AVL are negative. The associated features with this posterior fascicular block, posterior fascicular block are QRS duration normal or slightly prolonged, and increased QRS voltage in limb leads. The left posterior fascicular block, the electrophysiology is as under. The impulses, they are conducted to the left ventricle by the anterior fascicle, which inserts into the upper lateral wall of the left ventricle along the endocardial surface. The depolarization spreads from the endocardium to the epicardium, and thus the initial vector is directed upwards and leftwards towards the lateral leads. This produces small R wave in lead 1 and AVL, and hence a small Q wave in the inferior leads, that is 2, 3 and AVF. The major wave of depolarization then spreads along the free left ventricular wall in a downward and rightward direction, producing a tall R wave in the inferior leads and deep S wave in the lateral leads. This process takes up to 20 milliseconds longer than the simultaneous conduction by the both fascicle, resulting in slight widening of the QRS complexes. Because impulses, they reach the inferior leads later than the normal, there is increased R wave peak time in AVF, that is time from the onset of QRS to the peak of R wave. So the sequence of conduction in the left posterior fascicular block is, in this we can see the yellow line, it implies or it indicates the impulses are conducted to the left ventricle only by the anterior fascicle. Red arrow shows initial depolarization vector is directed towards the lateral leads, and blue arrow, it shows major depolarization vector which is slightly delayed and it is directed towards the inferior leads. So in this ECG, or in fact both ECG, we can see there are RS complexes in lead 1 and AVL, and QR complexes in lead 2, 3 and AVF. It shows right axis deviation as lead 2, 3 AVF are positive and lead 1 and AVL are negative. Here we can see Prolonged R wave peak time. The R wave peak time, it is a time from the onset of QRS duration, QRS, to the peak of R wave. In AVF, it is more than 45 milliseconds. In left posterior fascicular block, we should remember that this left posterior fascicular block is much less common than left anterior fascicular block, as the broad bundle of fibers that comprise the left posterior fascicle are relatively, they are resistant to damage when compared with the slim single tract that makes up the left anterior fascicle. So it is extremely rare to see left posterior fascicular block in isolation. It usually occurs along the right bundle branch block in context of a bifascicular block. So do not be tempted to diagnose left posterior fascicular block unless we have ruled out more significant cause of right axis deviation. For example, patients with acute pulmonary embolism, tricyclic overdose, lateral STMI, and right ventricular hypertrophy. The right bundle branch block with left posterior fascicular block. Here we get wide QRS, slurred S wave in lead 1 and slurred R wave in V1. The right axis deviation with dominant positive deflection in AVF along with RS pattern in lead 1 and QR pattern leads 3 and AVF, suggesting the left posterior fascicular block. So here we can see the right bundle branch block with left posterior fascicular block and right axis deviation. Dr. Norman Cousins has said the greatest force in the human body is the natural drive of body to heal itself, but that force is not independent of the belief system. With this, I conclude my today's topic. Thank you. Keep learning.